Good morning, everyone. So today we're going to be talking about headache as well as seizure disorders. So if you get out your first PowerPoint, what I'm going to do more so is try to go over my notes that you don't have that are necessarily on the PowerPoint. So many of you are all familiar with headaches. So with a migraine headache, typically the patient complains of pain on one side of the head as well as behind one of the eyes. So a tension type headache, it feels like the patient has a tight band or a belt that's encircling their forehead and around the head itself. So I'm going to skip over the slide with pain-sensitive structures. They include, you can read all that. And as you can also see that they do include cranial nerves. So headaches, they're classified as primary and secondary. So primary, these are not caused by disease or another medical condition. So examples are your tension type or migraine, or even cluster headaches that we'll be going over later. Secondary headaches, these are caused by another condition. So one example that people often get headaches with is sinusitis. It could be due to a neck injury, as well as brain tumors. So with tension headaches, also known as stress headaches, it's the most common type of headache. Essentially, everybody has stress, so I'm sure that you've had one of these in the past. And again, it's like having that tight band or belt around your head. It could be mild or moderate. This could be acute or chronic as well. And it affects both sides, so this is bilateral. Etiology and pathophys of a tension type headache, it's not fully understood, while there are some suggestions, such as it often involves from episodic to chronic. Chronic tension headaches cause diminished quality of life and severe disability. So some of the clinical manifestations with a tension headache is the bilateral frontal occipital headache. And again, it's that band-like headache. Also, too, patients often complain of neck pain. Massage is something good that you could do for this type of headache or suggest. Patients often have photophobia. That's a sensitivity to light, as well as phonophobia, which is sensitivity to sound. So there's no premonitory symptoms. So this premonitory, that refers to warning signs of an impending headache. These can occur from weeks, it could occur months or even years. Patients can also have a combination of a migraine and a tension type headache as well. So diagnostic studies for tension type headaches. History, obviously, you would want to look at a neuro exam, inspect for a local infection. You need to rule out sinusitis. So a lot of times I'll ask patients, if I tap, do some percussion over the sinuses, I ask them, is that tender? Does it hurt when I palpate over those areas? Also, you need to ask them if they have any drainage, yellow, green, because that also can rule out sinusitis. Other things that you need to rule out: anemia, dehydration. There is increased resistance to passive movement of the head. In EMG, this can reveal sustained contraction of the neck, scalp, or facial muscles. However, the patient may not show increased muscle tension with this test. So with migraine headaches, these are reoccurring. Like I said earlier, they can be unilateral. Typically, it's over the frontal or the temporal side. Patients often complain that it is a throbbing pain that gradually worsens with complaints of nausea, vomiting, or pain behind one eye. Now, you can have pain on both sides, but often it is one-sided. So some premonitory symptoms and triggers that you need to be asking about is the photophobia, the phonophobia, and also patients can complain of scotomas. So scotomas, these are little blind spots in the vision. Like if you look straight out, you might notice patients will complain of seeing this little brown spot. That's a scotoma. Often these occur between 20 to 30 years of age, and it affects females more than males. So some risk factors would include a family history, low-level education, low socioeconomic status. Obviously, if someone has low-level education, maybe they don't have a good paying job, perhaps they're under more stress. Frequent tension type headaches without an aura. These are most common migraine. With the aura is classic migraine. So etiology and pathophysiology with a migraine. Again, the exact cause is unknown. There's a common theory that it's a complex series of neurovascular events initiates a migraine headache. There's also a genetic factor with this. It accounts for 50% of an individual's risk for migraine headache. Migraines may or may not have a known precipitating event or factors. Sometimes food triggers, if someone smells chocolate, cheese, that could bring on a headache as well. Also, if someone misses a meal, that can trigger a migraine. So some clinical manifestations that you see, your premonitory manifestations, the photophobia. It could be psychologic. The patient could be experiencing hyperactivity as well as irritability, as well as food cravings. So with an aura, that's visual symptoms such as bright lights, the scotomas, blind spots that I just discussed. Also as well, zigzag lines. Patients might complain of those. It could be sensory, voices, sounds that do not exist. It could be a strange smell that someone is having prior to the migraine. Patients can also have motor weakness, paralysis. They may feel that the limbs are moving. These can last up to 4 to 72 hours as well. So diagnostic studies, we discussed a history. There's no specific lab or radiologic test such as a CAT scan and MRI. These typically are not recommended for routine evaluation of a headache unless the patient has a positive neurological exam that reveals abnormal findings that may suggest a brain tumor. Often patients who do complain of a headache, typically physicians or healthcare providers, typically the patient will have their vision checked because that can give headaches as well. Personally, my dad, he was having headaches, and here he ended up with a meningioma. And of course, that was diagnosed on an MRI. Cluster headaches, these are more severe. They generally occur at the same time of day or night. The onset is between 20 to 45, and men are affected 3 times more often than women. I've never had a woman who's had a history of cluster headaches, only men. So again, with the etiology and pathophys, neither the cause nor the pathophysiologic mechanisms of a cluster headache is unknown. Typically, it is unilateral pain, and it can occur with activation of neurons in that trigeminal nerve. Patients have dysfunction of circadian rhythms. This is irregularities in melatonin and cortisol. Other things that can trigger it are alcohol, strong weather, weather changes as well. So clinical manifestations, something that you need to watch out for. Patients often complain of sharp, stabbing, intense pain. This can last 2 minutes to 3 hours. So when I'm thinking of a cluster headache, in my mind, I'm picturing an adult male who reports onset of a severe headache behind one eye or the temple, accompanied by tearing, okay? And also, one thing that you may notice with your patients is that they will develop ptosis, and that is drooping of one of the eyelids. And so that is spelled Ptosis, so you need to know that. Miosis, that's a constricted pupil on the infected side. These can occur several times per day. Let's see what else. And again, more common in men, 30 to 40. Males can be at a high suicide risk due to these headaches because they're very severe. So treatment typically for this would be sumatriptan or Imitrex by injection, not tablets. Another thing that you can do for these patients is they can be placed on 100% oxygen, 6 liters per minute by face mask. So turning to the next slide, pain locations. So again, on the slide, you'll see the tension headache with that band wrapped around the patient's head. B, you have the migraine headache, which is very intense, and typically it affects the frontal or the temple side. But again, they can be bilateral. And then you have that cluster headache. The pain is around one eye. Often it's sharp, penetrating, and burning. So other types of headaches, obviously I mentioned brain tumors in the past. Trigeminal neuralgia. So with trigeminal neuralgia, this affects cranial nerve 5. And it's an episodic severe shooting or lacinating pain in the cheek. It's always one-sided, and it's triggered by touch, talking, chewing, and cold air. Pain can last a few seconds to minutes. So with trigeminal neuralgia, these patients, they need to avoid those triggers. It's typically treated with Tegretol or Dilantin by mouth. Patients can take this daily or twice a day until it's resolved. Other things that can help with trigeminal neuralgia is maybe a nerve block or surgery. Obviously, symptoms vary greatly. with each patient. So other things that you can suggest to your patient, yoga, relaxation training, such as acupuncture, possibly hypnosis. So when we talk about drug therapy, and obviously this is something that you guys are going to need to know for the quiz, tension type headache. So for a mild to moderate headache, it's typically treated with aspirin, essentially acetaminophen, Tylenol. That's typically your go-to, what you suggest your patients to take first. They can take NSAIDs as well, or in a combination with sedative, muscle relaxant, tranquilizers. There's also what is known as preventative. And so a drug class that is preventative is tricyclic antidepressants. An example of this would be amitriptyline. It's also known as Elavil. The only thing with Elavil, it's very sedating, so typically patients should take this at bedtime. With the anti-seizure medications, Topirmate, Topiramate, also known as Topamax is the brand name. So this is used to prevent migraines, and this is something that has to be taken for several months to determine its effectiveness. Another medication would be Depakote in that drug class for the anti-seizure meds. Another thing that you need to discuss, patients' lifestyle. Do they drink a lot of caffeine, maybe cutting back? So I'm moving on to the interprofessional care of headaches. So for moderate to severe headaches, triptans have become first-line therapy. And some examples, one that I mentioned is the sumatriptan, also known as Imitrex. Maxalt or Zomig is in this group. So typically triptans, they are the most effective when taken at the onset of a migraine headache or during the aura. So one thing that you should know that triptans, they are contraindicated in patients with someone who's had a possible MI or is at risk for a myocardial infarction, as well as coronary artery disease, stroke, DVT, PE. These are very serious conditions, so obviously you want to avoid triptans in patients who have experienced any of those that I have mentioned. There's also another medication. It's called Zecuity, and it's spelled Zecuity, and it is a transdermal patch. This is the first skin patch indicated for the treatment of a migraine headache. Also, it's good for intense nausea secondary to the headache itself. So it can be applied to the upper arm or thigh. It can cause some irritation to the skin. So patients should rotate those patches. I personally myself have never seen anybody on a Zecuity patch before. So with migraine headaches, prevention, obviously avoiding those triggers. I mentioned the anti-seizure drugs. So the Topirmate that I mentioned, this is given daily for prevention. You take it for 2 to 3 months to determine the effectiveness. Some side effects that you would expect would be hypoglycemia or weight loss. Patients also have had Botox. This is generally for chronic migraines lasting greater than 4 hours or more, at least 15 days each month. Typically, patients are given multiple injections in the head and neck. It lasts up to 2 to 3 months, and it's repeated every 3 months. An adverse reaction would be swelling and pain. Other things that patients could take: selective serotonin reuptake inhibitors. An example would be Prozac. These are also good for depression, mood, also help with stress. As for interprofessional care for cluster headaches, patients, a good thing that they can do is use the 100% oxygen at 6 to 8 liters per minute for about 10 minutes. And so this causes vasoconstriction, and it increases the making of serotonin in the central nervous system. This can also be repeated after 5 minutes. So these patients, they typically have 24-hour access in their home oxygen, a tank. So preventative medication, high-dose verapamil, that is first drug of choice. Other options would be lithium, ergotamine with some caffeine, invasive nerve blocks, deep brain stimulation, and so on. So for your nursing assessment, nursing management, always make sure that you get a good history. Ask your patients if they're taking nitroglycerin. That's kind of key. It can alert you if the patient has a cardiac history, because obviously you want to avoid triptans with patients who have a cardiac history. And of course, when you're asking your patient about the headaches, have them point to where it is. Is it frontal, temporal, behind one eye? Is it wrapped around the head like a tension headache? Ask if there's any precipitating factors. Do they have aura or no aura? So when you think about objective data, does your patient seem anxious? Do they have any diaphoresis? Do they have any ptoses, drooping of the eyelid that I mentioned? I'm going to skip over nursing diagnoses. Planning. One thing that you can always suggest to your patient, if they feel a headache is coming on, to encourage a quiet, turn the lights down environment, just going down, turning off the lights in their bedroom, and just taking a rest. That can help. Other things, if a patient does have those tension-like headache, massage is good, heat packs also. Dietary counseling, since food can trigger headaches. Educate your patient on foods such as chocolate, cheese, oranges, tomatoes. Have the patient maybe keep a log of what they're eating if they feel like this is related to food. They also need to avoid environmental triggers such as smoking, strong perfumes, gasoline. Patients who have cluster headaches, these can occur at high altitudes with low oxygen levels during air travel. So I think that's wrapping up with headaches. I'm going to make a separate video for seizures. Also, I wanted to let you guys know that documentary, I talked to Jamie Brogan the other day, and we're just going to go ahead and cancel that. I think that's something that we want to do on campus and as a group. So I am going to look up some questions, and I'll post those for some extra credit points. And I'll probably end up working on that today. So the next video that I'll follow up with is seizures. Thanks.